can get into a fight with Grant.
For those of you who don't know me, I'm Tom Muro. I'm one of the interventional cardiologists from Stanford. I'm the one that lets all my patients die. The gazillions of them that don't. What we're going to talk about today is 12 EKGs. And how many people were here the last time that I attempted to give this up? Okay. I will admit, last year's lecture was an absolute dud. It was terrible. It was horrible. And I apologize because it was confusing, it was misleading, and I don't think it was helpful at all. So I tried to revamp it, and Mary and Caroline helped me out the last couple of days trying to focus me in on doing the right thing. So we're going to give this one another shot. First, I'm going to start with a little bit of background on sort of the whys, why we want to do this thing, and what my thoughts are. Part of this process, part of this educational process here is beyond what you are going to be doing as EMTs, or at least right now. Like, part of what I want to do here is train you about the physiology of what's going on in the heart, or the electrical physiology of what's going on in the heart. So you can just start thinking about these things as we start making diagnoses, and as you start treating these people as you're bringing them in. The more you know about the heart, the better you're going to be able to treat them acutely in the field, on the bus, and as you bring them in. And hopefully, as you go forward in your careers, which I hope, of course I still hope all of you go into medicine, you'll start learning this and it will become more and more appropriate to you. The second reason why we're doing this is I've felt for a very long time that EMTs should be performing 12 EKGs in the field, that we should be allowing EMTs and first responders to make the diagnosis of acute MI so that we can improve our ability to and shorten our door to bleed times. It is something that is actively under discussion of whether we're going to start training you guys to do it and to start doing it in the field, hopefully so that when you get that intercept with SEM, with the paramedic, and then have a 12 EKG that's already there, and then we can then get that activation early. In a way, what we're trying to do is ensure that what's happening in Darien is the same and getting the same level of care as what's happening at other areas in Stanford and at other areas around in Fairfield County. Because in the other areas, NICVAC and in GEMS, they're doing 12 EKGs in the field as well as obviously SEM. So this is something that I think that we can do. Now, the big limitation is going to be, can you guys do it appropriately and not screw something else up? Of course, I believe that you can. I hope you'd be able to do this. This is not a difficult skill to do. I know that it's an extra thing, but it's something that I obviously think that you can do. And for years, when the interns, up until this year, when the interns were rotating through with me, we had them performing 12 EKGs in my office. So obviously, if I trust them there, I can trust them in other places. So first off, what is a 12 EKG? Well, 12 EKG is essentially, I'm going to use some terminology that some of you will understand, some of you don't, but it's essentially a vector map of what's happening electrically within the heart. With each muscle cell contraction, there's a small change in electricity in that cell. And if you add them up in one direction versus another direction, you'll get little blips, and if you put leads on the chest, you can read those things. You can read those blips. As the last, I'm going to talk about the electrical stuff because that's where I really screwed everyone up last year. The EKGs were initially started, the first one was done in 1903 by a man named William Einthoven. The technology of EKGs has not really changed dramatically. It's the same electrical system. The only thing that's changed a little bit is our ability to understand what's going on with it, and the size and the shape of the machines. When you're going to be doing it in the field, it's going to be on a little 12-pack that you have that's associated with your defibrillator. You'll just hook the leads up and they'll spit you on EKG. There's nothing to it. And the EKGs are automatically read. Your necessity to make a diagnosis, at least initially, is not going to be important. It's just going to be the physical thing of doing EKG. And that's what we're going to go about first, and then after that, we'll talk a little bit more about EKG. Dr. May, I'll switch around. So here's the physiology. Everyone know what this is? Good, okay. Definitely. Okay, so the heart has, I've done this bit about 10,000 times, so if it sounds a little bit, the heart has 4 chambers, we all know them, right? The right atrium, which gets blood back in from the body, from the inferior vena cava, and the superior vena cava, into the right atrium. It goes across the tricuspid valve, into the right ventricle, which is the chamber that pumps into the lungs. Oxygenated blood then comes back from the lungs in the pulmonary veins, in which there are 4, into the left atrium. Holding chamber, holds it there for the fit. And then it goes across the mitral valve, into the left ventricle, and then it gets pumped out the aorta to the body. In order to do it effectively, you want the blood to come from into the atrium first, and then be sort of ejected together, somewhat together, into the ventricle. They want these things pumping at the same time. You want one to pump into the other one outward. To do it, you have a small set of, it's almost like a spark plug. It's called the sinoatrial node, SA node, and it's your body's pacemaker. It's what starts the heart. And just very briefly, there's a little electrical current that is going into these cells. At some point, it hits a level that opens up gates and allows a lot of electrolytes to rush in. You have a rush in of the electrolytes, and then the muscle contracts. And then it pumps those electrolytes out, and it waits for the next. It waits for the next. As these contract, it then stimulates the cell next to it. And then essentially in a wave, all the cells of the atrium will contract all at once. Pretty much at once. But it's actually a wave across the muscle tissue of the atrium. As it's coming down, it hits a barrier at the level of the valves, the tricuspid valve and the mitral valve. There's a fibrotic barrier here that will not allow electricity to go down. So it will stop here. But in here, there's a set of cells called the AV node that slows everything down a little bit. It acts a bit like a capacitor, not truly, but a little bit like a capacitor, where it slows it down, and then quickly the electrical system will, or the electrical signal will quickly go down modified nerve tissue. It's called the bundle branches, left bundle branch and this right bundle branch, down to the tip of the heart, and then the heart contracts from the bottom up. Okay, and then blood gets pushed out to the lungs, to the pulmonary artery, and to the okay. When we put the EKGs on the surface, these will make specific patterns, and a lot of what we're going to be doing in a bit is going to be about pattern recognition. Essentially, when the atrium contracts, you're going to have a deflection. Let's call it P wave. Or P wave. Then there's a delay, which is referred to as the PR interval. And it's the delay that's going through the AV node, set of cells just beneath it called the bundle of His, and then down the bundles before it goes to the heart. Then we have the QRS complex, big one, which is when you're watching, what show do you guys now watch? It used to be ER, but now it's something different. Grey's Anatomy, right. Yeah. I saw that once. It is sub-mental. I do not watch it. It is awful. I watched it for 5 minutes. Okay, but anyways, that's what you're seeing on the, when you see the big screens of the dip, that's the QRS kind of thing. And then you have the T wave. There's actually a Q wave for you. And then there's the next one. Okay? Does anyone know why they're called QRS T? Is that, yes, good. I understand why they let you decount. Good. Why are these not other letters? Okay, nobody does know. It's actually a trick question. Nobody knows. That's there's one initial EKG that they have that has it as A, B, and C waves, but we believe it's because X, Y, and Z were used for other electrical designations at the time, and so they sort of were working back in the alphabet. But that's one of those things lost in time. But these are going to be the designations. Okay, so the P wave is with the atrium contracting. The PR interval is essentially your AV node. The QRS is as you're going into the muscle. So this is the ventricular contraction, and the T wave is repolarization. And then you have the delay until the next beat starts. Okay. Does that make sense? Okay. So when we're talking about EKGs, we can have abnormalities in the atrium, the way that the atrium contracts, and the way that the signal goes across the atrium. We can have abnormalities coming out of the sinoatrial node. We've got different sinus nodes, and a little bit of these. We can have problems with the AV node and the conduction through it. It can be too slow. Sometimes it can be too fast. We can have problems with each of the bundles. And so you can have something which I'm sure you have heard about, a left bundle branch block or a right bundle branch block. That has specific EKG patterns. And then patterns of problems with repolarization and acute injury patterns in the T wave, or what's referred to as the ST segment. So when we talk about STEMI, it is a ST segment elevation MI. This is where it comes from. This is the ST segment, which is this part of the QRS pattern, the QRS and the repolarization. That's going to give you the acute injury. I'm going to look at one of those pictures. Okay? Does all of this make sense? Because it's sort of important that you know what we're talking about, the structure, because once you know the structures, then you can sort of divide up in your mind about how you're going to read these EKGs and what we're talking about with each segment. Okay? The next thing about the EKGs. EKG here in front of you, right? There are, if you can see here, there are 12 different segments, and then underneath there's rhythm strips. But when we talk about 12 lead EKG, it is the 12 leads that are on here. When you read down them, and everyone can see this. As I'm reading down, I'm reading on EKG number 1 right now. You have lead 1, 2, 3, AVR, AVL, and AVL. These are precordial leads. These are leads that are, these are limb leads. These are limb leads. So these are leads that are sort of going around the body in this direction. And we'll tell you where each of these are. And then the precordial leads, which go around the front of the heart, are V1, V2, V3, V4, V5, and V6. So how do you do it? Here's your person. So the nice thing about EKG leads is that they're all connected. And so you just have to look at the lead to know where to put it. So this should be right arm, right leg, leg, left arm. You can put these leads anywhere you want on the arms or legs. You can actually even put them on the bottom of the torso, but it's not quite as good. You can put them on the legs itself. You can put them on the shin, you can put it on the thigh, you can put them on the forearm, you can put them on the shoulder. It doesn't matter. You do want to put it in a place that's somewhat stable and that they're not moving around very much. Then you're going to put the precordial leads on. These are the ones that are a little bit hard. So there are 6 leads. The first lead is going to go down right next to the sternum in the 4th intercostal space. And so to do that, you're going to find the clavicle. You're going to go down. That's the 1st intercostal space. Then you find the rib. That's the 2nd intercostal space. Then you're going to have a rib. That's the 3rd intercostal space. Then you have a rib. That's the 4th. D1. Okay? So 4th ICS. D2 is on the other side of the sternum in the 4th intercostal space. And now I'm going to get tricky. I'm going to move down to V4. V4 is in the mid-clavicular line in the 5th intercostal space. So you're going to find the clavicle. You're going to right in the middle of the clavicle, and then you're going to move right down from it in the 5th intercostal space. The reason why I'm skipping number 3 is number 3 goes where? In between 2 and 4. Exactly where it should be. 0, 3, 3. D5 is going to be on the lateral aspect of the clavicle, and D6 is in the axilla. Again, in the 5th intercostal space. So you're going to walk your hand across that intercostal space and walk it around. And that will tell you exactly where it is. Women who, one very important thing, as you're doing the 12 lead EKGs, women should not be wearing a bra because you will put it in the wrong position. If you think that you need to do a 12-lead EKG because it's important to do a 12-lead EKG, do it correctly. If you do it incorrectly, you're going to get bad information and you can be misleading and maybe dangerous. Women should not be wearing bras when they have EKGs on. It puts them in the wrong space. In addition, when you have pendulous breasts, the breast tissue comes over these leads. I can't tell you how many times I've walked in and seen technicians in our hospital performing 12-lead EKGs and put the leads on top of the breast. Absolutely wrong. So it goes underneath the breast, and this space is where they're supposed to be. If you put these leads up too high, which happens not infrequently, you can inappropriately get ST elevation and abnormal T-wave and T-wave inversion. And probably once or twice a year, I'll have a patient come into my office because they have an abnormal EKG. And I redo the EKG and say, it's completely normal. And then I look back and I compare and I realize the reason why they were having all this workup, they probably got a stress test, got the nuclear isotope, and got blood tests, etc. All this stuff because someone put their electrodes too high. So you have to be, you want to do it, if you're going to do it, you want to do it right. Now, count up the number of leads here. 1, 2, 3, 4, 6, 10. But we have a 12-lead EKG. That's because the limb leads actually are derived into 6 different EKGs, or 6 different channels. Right? So that's why it's a 12-lead EKG, but you're only putting 10 leads on the patient. These EKGs, these leads, are going to give you sort of north-south. Where in the body are you? In which direction in the body are you going? These leads, I'm now going to cut the patient like this, are going to give you anterior lateral. So when we start looking at this EKG, when we go down, we 2, 3 in AVF are inferior. 1 in AVL are lateral because you're going this way. AVR, don't worry about it, it's actually over here. No, don't worry about that. And then V1, V2, V3 are here on the front of the heart. V4, V5, V6 are in the lateral line. That is a very simplistic view of what's going on in the EKG. Now, there's actually a lot more to it where, which lead is going corresponds to which artery and how you're going to diagnose the artery and what else could be happening. And that stuff we'll leave until we get into this in markedly more detail after your first year of medical school. Does this make sense?
Can you just run down the cut from here? I don't have glasses to see the V1, V2, yeah, those, where those go?
One more time. Okay. So that's the sternum. Right next to the sternum, in the fourth intercostal space, is V1. So down here, 1, 2, 3, 4. Okay. That's V1. V2 is in the fourth intercostal space on the other side. V4 is in the fifth intercostal space in the mid-clavicular line. Down from the clavicle, straight down. That's V4. V3 is between V2 and V4. We can do it this way. V6 is in the axilla in the fifth intercostal space, and V5 is between, or you can say that V5 is at the lateral aspect of the clavicle in the fifth intercostal space. Okay? So essentially, fourth intercostal space, fifth intercostal space, and then right in between. Not a difficult thing to do. So I guess we can just we'll go first over to the first EKG. And these are, again, I want to keep this relatively simple. We have 9 EKGs that we're going to go through. And we're going to go through them quickly. This is now pattern recognition portion. This is the Aunt Millie portion. And I talked to the guys in SEMS when we were doing their EKG stuff. It's sort of like, how do you know who Aunt Millie is? Because it looks like Aunt Millie, right? You know who it is. So it's just pattern recognition. That's what we're going to do, more than just with a little bit of physiology in the background. But otherwise, I want you just to start looking at them and getting comfortable with it. And then we'll go on as we go forward and try to teach you how to do these and interpret them, and you can all become electrophysiologists. Which, by the way, truly bores me. I would prefer to be opening up coronary arteries. Okay, so EKG number 1, what you're going to see here is a normal EKG. Let's go back to our picture of the heart. How am I going to say this so that makes sense? Okay. So when you're going through this again, it's just going to be, we're going to work left to right, and then we're sort of going to go sort of around the part so that we're just going to repeat what we just said as far as all the other things that's happening. Okay, so if we go into, let's use lead 2. Okay? Lead 2, which is a great lead. Lead 2 is the lead that you often use to define your rhythm, because it gives the best view of the P wave. Don't worry about why, but it's the best view of the P wave. That's how it looks. So what you're going to see as you go across in lead 2, and that's where the first rhythm strip is, you'll see a P wave, you'll see a little delay, you'll see a narrow QRS complex, and then a T wave. And then space, P wave, space, QRS, T wave. Okay. This is referred to as normal sinus rhythm because you're sinus rhythm from the sinoatrial node, coming down and taking the atrium contract, followed by an appropriate AV conduction into the ventricle, and then a normal QRS complex. And then read it, normal sinus rhythm, normal atrial. All that pretty good. The P wave is upright because when we did this picture of the heart, we have the left arm, left leg, right arm, right leg, left leg. It gets translated into lead 1, lead 2, lead 3, AVR, AVL, AVF is. So if you have a lead 2, for example, the things that are going down towards lead 2 are going to be the most positive. And as you see here, it's going downwards in the heart, and your contraction pattern is going to go down towards that lead 2. That's why you have the positive, why it's most positive in that area. You'll see that the delay between the P wave and the QRS is always shorter than one of the big boxes that you can see. And each big box represents 0.2 seconds, 200 milliseconds. Beyond that is something called AV delay, which we can talk about later. But you'll see that there's a close association between P wave and QRS, that the QRS is narrow. The reason why it's narrow is because it's coming down rapidly down these two bundles, and then both of the ventricles are contracting at the same time. That's going to become important as we start talking about other delays and blocks. So this is normal. As you do normal, let's go over to the precordial leads, V1 through V6. You'll see that the first wave of the QRS complex starts going upwards. And then it goes more upwards. And then more upwards again. And then over here, up, up. And then the biggest one is in V4 and V5. This is called an R wave. When we start talking about EKGs in nomenclature, when we talk about the QRS complex, the first upward wave is called an R wave. The first downward wave, if it precedes the R wave, is the Q wave. If it's after the R wave, it's an S wave. If there are two R waves, it's called an R and R prime. Just to be continued. So we'll here start talking about the R wave, the R wave progression, and Q waves. The reason why Q waves become important to you guys and important to us is that Q waves are an indication of prior heart attack, because the Q wave is essentially telling you that the electrical pattern is avoiding a set of a portion of heart muscle. And as it's avoided, that heart muscle gives a dip. Because at this point, it's going all away from that segment because it can't contract through it because it's dead muscle. Okay. So this is a normal EKG. Let's go on to EKG number 2. So in EKG number 2, you'll notice that there are no specific P waves there. It's up, the line's all wiggly. And in addition, the QRS complexes are no longer regular. They're not spaced out every 4 boxes or every 5 big boxes. They're now, sometimes it's 3, sometimes it's 5, sometimes it's 2. So you have an irregular baseline and irregular QRS complexes coming through. And this is called atrial fibrillation. How many of you have heard about atrial fibrillation? So atrial fibrillation, what's happening with AFib commonly is that in the pulmonary veins coming back from the lungs, you have tissue in these veins. And this tissue can have abnormal electrical signals that are just essentially constantly firing out electrical impulses in random fashion. And it's making the tissue in the atrium contract wildly. It's just going around, and around, and around, and around, and around. Such that the atrium actually don't contract together, they just sort of wiggle like this. And this wiggling is what you're seeing on the baseline, this wiggling pattern on the atrium. As that's occurring, the AV node is being bombarded with signals at the rate of somewhere around 300 beats a minute, or the equivalent thereof. And the AV node is trying to sort of allow the electrical signal to come through when it, to sort of slow things down. Its job is to sort of regulate how much electrical signal is coming from the top of the heart to the bottom of the heart. Just like I said, it sort of acts like a capacitor, although the electrical engineers and you guys, it's not truly a capacitor. I didn't say that, but you know, it comes through here, it slows down, but because the signal is coming in irregularly, it is irregularly going to have the signal come down the bundle branches and into the ventricle. And that's why you have an irregular rhythm in the ventricle as well. The big issue with atrial fibrillation, as you guys know, is stroke. And the reason why, commonly, you have a set of tissue in the atrium called the left atrial appendage. You don't know exactly why it's there, but it's there. It's probably just a holdover from how the heart develops in utero. With this not contracting, you can have eddies. And these flow eddies, there's not a lot of flow into the atrium. A clot can form, and that clot gets thrown into the ventricle and then potentially to the brain, causing a stroke, or kidney failure. But that's just sort of a side note. But you can see here that, at least in this EKG, the QRS complex is still now because you're having appropriate conduction down the bundle branches, and both ventricles are contracting simultaneously. Let's go on to EKG number 3. EKGs are really not that exciting, I realize. But we're going to get to the more exciting side. Okay. So EKG number 3. What do you notice is different between EKG number 3 and EKG number 2? Anybody?
A lot more activity
Yes,
going on.
right. It is, what's happening with the QRS? We're correct, it is something with the QRS. Nope, so it's not more regular. It is more what? Nope, not necessarily more or less irregular. They're both irregular. It's faster, right? There's a lot of them in the same space. I guess I should step back for a second. Let's do a second about timing. Each one of these dark lines that you see here in the grid represents 22 milliseconds. That means that 5 of those, what we refer to as big boxes, because inside those are little boxes. 5 of the big boxes is 1 second. Every EKG is essentially done at the same speed. You can speed it up if you want, you can slow it down. But for what we do, almost all of them are done at exactly the same paper speed. So now you have a lot more QRS complexes in the same amount of time. So the chart's going to be really, really rapid. So what's happening here, same atrial fibrillation, but now you have an AV node that's allowing the signals to come through very, very quickly. So this is referred to as rapid atrial fibrillation. Get it? Okay. So very commonly, you're going to see this a lot. Let's go to EKG number 3. Okay, so EKG number 3. What's different between EKG number 3 and EKG number 1?
You need 4?
Which one are we on?
I'm doing one. 4. EKG number 4. I skipped forward. EKG number 4. I'm going to track it. So, what do you say? More P waves. Okay. When you see these P waves, this is a great one. So the P waves like this. They're happening a little bit more than 1 box per, a little more than 1 per box. So 5 per second. So about 300 beats a minute. This is called atrial flutter. And what's happening with atrial flutter, which is interesting, is very similar to atrial fibrillation, except that the pattern of, instead of being completely irregular, there's a rapid pattern with a short circuit that's happening around, usually around the tricuspid valve, where it's coming, hitting here, going back, coming back, hitting here, going back. And each time it gets to this point, it tells the atrium to contract, and then trying to go send information down the AV node, or electrical signals down the AV node, but it only does it every 4th or 5th time. So this is a flutter with a normal ventricular response. But the sawtooth pattern is what makes that distinction. Now, there are times when you'll have atrial fibrillation that will look more like atrial flutter, and there are times when you'll have atrial flutter that looks more like atrial fibrillation. And you should leave that to the electrophysiologist to discuss, because again, the voice can be tears. Okay. So that's atrial flutter, but this is another one, again, pattern recognition. Just look, you'll see that sawtooth pattern in the baseline of the EKG. Now let's go on to number 5. So,
when you just look at this, are you going straight to the second lead? The strip 3 up from the bottom?
yeah, for this one, the lead that's at 2 that goes all the way across
That's
the
the
rhythm.
one that you.
That's the one I'm saying, oh yeah, look at that pattern. But you can actually do it from any lead. Truly, you can do it from any lead. But lead 2 will often be, and I'm not going to say always, but will often be the lead that you're going to be reading your rhythm from. Now it's good now, the new EKGs, they have multiple rhythm strips on them. The old EKGs didn't. Actually, the old EKGs used to have one sticker that you would stick in one position, get a small strip, in the next position, get a small strip, third position, get a small strip. And the initial EKG actually had buckets of water, and buckets of water for the feet and the hands, and then had a big machine in the next room. It was about the size of this stage. They're a lot smaller. Okay. So let's go on to EKG number 5. And now going back and forth between 5 and 1, what's different about EKG number 5? D waves are bigger? Correct? What else is happening? Sorry?
The small QRS complex.
There are smaller QRS complex in the limb leads. Look at the precordial leads. Not necessarily smaller.
Oh, it has the deeper thing, so it has a history of MI.
It could potentially be a history of an MI, but this is a specific pattern that's beyond that. Because now you have a wide pattern. Remember they talked about ventricular tachycardia being a wide complex tachycardia? I'm sure you remember this when you took the ACLS. You took your ACLS, half of you should remember this. So we talked about wide complex tachycardias versus narrow complex tachycardias. Does this sound right to you guys? You've heard this? Okay. So when we talk about wide complex tachycardias, that's because of where the signal is coming from. And this is the QRS here is wide. And wide we define as greater than 120 milliseconds. So it's 2/3 essentially of one of the big boxes. So when you look at the QRS, it looks like, and we'll use V2 because it's the biggest one. Go up, it's way down, and then like that. And from here to here is 140 milliseconds. Whereas the normal one that we usually saw in V2, if we go back to EKG number 1, it's like this. And the whole thing is less than 80 milliseconds. So what's happening here is, normally you have 2 bundles, right? One that comes down the left side, one that comes down the right side. In this case, the left bundle is not allowing electrical signals to come down. So your contraction starts on the right side, goes all the way around and then comes the left side. So it takes a lot longer for the contraction to occur because it has to go all the way around before the heart's being stimulated. As it's going around, it's going to start here, it's going to go this way, go this way, go this way. So the time at which it's going to hit or go towards these leads is going to be delayed. And that's why you have a wide complex. The same thing happens, for example, if you had let's say for argument's sake, you have a heartbeat that's starting in the ventricle. It starts here. Well, in order for it to make its contraction, because it's not using the bundles, it has to send the signal all the way around. It's not using the bundles. If you have this rapidly from the ventricle, it's referred to as ventricular tachycardia. And ventricular tachycardia, by definition, is a wide complex tachycardia. So when we start talking about wide complex tachycardia versus narrow complex tachycardia, that's because wide complex tachycardia in general come from the ventricle. And narrow complex tachycardia from above come down and have a narrow complex because both of the ventricle systems are contracted together. Let's go to number 6. I'm going to ask the same question, number 6. So this is another wide complex. But instead of having the initial small R wave and the big S wave coming down, a big Q wave, usually is an S wave coming down of the left bundle branch block. Instead, in this one, you have something that looks like rabbit ears in lead V1. Okay? There's a small, in this actually V1 in this one, there's a small R wave, there's an S wave, so this is our big R prime. This is what's called right bundle branch block. So instead of the left bundle branch block being blocked, now you have the blockage here, and it's going around this way, going around the opposite way. So we can identify where the block is based on the morphology of, based on the picture on the EKG. And it becomes important when we talk about ventricular tachycardias and atrial fibrillation with rapid ventricular responses and aberrancy and all these things that we'll talk about in the future are going to be based upon the fact that we make an assumption of how the electrical pattern is coming out of the heart. Now let's go on to number 7. This is getting confusing. Now what's happening in number 7? Let's go to this side of the bridge. Now I understand that there's a hierarchy here. I didn't realize this until recently. That there's like freshmen. Where are the freshmen? We're there, yeah. They relegate to the floor. Isn't that cute? And then the sophomores are back there, right? And then we have the juniors over here. Getting this correct. And then the seniors are over here, or just correct this is all thing. Yeah, except for your juniors don't do that. All right. Let's ask one of the juniors. Okay. So it would be unfair to ask a question. We're supposed to be the smart ones. I'm not going to ask the seniors because they're already going to college. Okay, so juniors. Now, I've given you a hint here. I've put a lot of little arrows on the bottom. Use the hints. So what's happening in this EKG that's different from the other EKG? Don't all child answer once. Yes.
There's no Q wave?
No Q wave. No. That's not, you're correct, there is no Q wave, but that's not the intro.
Is it that, like, it's really slow?
The QRS complexes are slow.
Yes.
Right? When you look at the QRS complexes, they're going at 30 beats a minute. It's now, instead of 5 boxes, which would be 60 beats a minute, it's 10 boxes. So the patient's heart rate is really slow. It's not contracting like the one. What's happening with the P waves, though? Where are the P waves going?
Non-existent part.
There are a lot of P waves. That's why I've marked them all out. P waves are regular. P waves are going at a regular rate. But in this case, the P waves are not associated with the QRS complex. Remember before we were talking about there's a P wave, and then you get it goes down the AV node, and then you have the QRS complex. And so for every P wave, there's a QRS complex, and then there's a P wave, and then a QRS complex, and a P wave. That's normal. And in this case, there's a P wave, there's a P wave, and there's a P wave. And then somewhere in the middle here, there's a QRS complex, there's a P wave, a P wave, a P wave, and maybe a QRS complex or not. And if you really look at it closely, you'll see that they're not associated at all. So what you have here is called atrioventricular dissociation. The P waves are happening on its own, the QRS complexes are happening on its own. And usually when that happens, the QRS complexes are very slow. What this patient needs is, it is similar to atrial flutter, but in atrial flutter, the difference is that some of the signals are coming through the AV node. In this case, the AV node is completely blocked. And you have a rhythm that's coming from somewhere, it can be coming from anywhere in the ventricle. In this case, it is narrow, so it's actually coming from somewhere up here. But that's just my luck. But that these are not associated directly, where with atrial flutter, it is. Atrial flutter, as it's going around, it will go around 3 times and then come down. 3 times and then come down. Right, it's consistent with this is disassociated. So in this case, what this patient needs is a pacemaker. It needs somebody to either reconnect the atrium and the ventricle, or at least to make sure that the ventricle will continue to contract. Because what can happen here is that the ventricle can just stop. What happens when the ventricle stops? The patient dies. Good. So I think it was a freshman who said that. Good. Say yes.
Is this patient unconscious?
No, probably not.
Okay.
I mean, not necessarily. They could be lightheaded, dizzy, loopy. When I was in training, my heart rates were 38 to 40 beats a minute when I was resting, so I think I was conscious. But so it doesn't have to be unconscious. Sometimes they will be. But what you'll see is that the pulse will be very, very slow, and you're worried about the fact that the delay can become even longer. So when you're seeing these things, the delay, it just happens that the delay is going at 30 beats a minute here. It could be 20, it could be 40, it could be 60. But with dissociation, when the P waves aren't contracting to regardless of the cause, if you have dissociation between the P wave and the QRS complex, that's a big deal. It's AV dissociation, and it needs a pacemaker unless there's some other reason why Dr. Gallo has figured out how to avoid it, or giving him calcium or not giving him calcium. Okay, that's a nice thing. Okay. Now let's go on to number 8. Okay, a lot of stuff going on in the break. We're done here. We've got 2 more. We're going to do it in 2 minutes for each guys. So, number 8. Let's go to the precordial lead. You know, the precordial leads are V1, V2, V3, V5, V4, V5, V6. These are the precordial leads. We talked about the QRS complex. And I'm going to draw V3 again. Okay, so there's a Q wave, which we talked about is an indication of a fire or maybe a current heart attack. And then what's happening in the ST segment? All right, it's up. And there's actually a point here called the J point, which we're talking about because you may hear me say it. That's where it sort of curves up. So this is someone having an ST elevation MI. And we can tell because it's in these anterior leads, and it's an anterior ST elevation. This patient is having an infarct, probably somewhere just after the first diagonal branch. And it goes from V3 through V4. And you can also see, just to complete this, in 1 an AVL as well. So it's also lateral. And we normally talk about inferior and lateral aspects of the limb lanes. So you see in 1 an AVL as well. So this patient is having an anterior lateral MI. Someone have a question?
Yeah, how many boxes have to be up the emergency elevator?
That's it. The classic definition is 1 box up, 1 little box, not big box, 1 millimeter up, is a definition for an MI if it is in 2 consecutive leads, and 2 boxes if it's in the anterior precordial. So 1 little box, and remember each of these big black ones that you see here is 5 boxes. Each little one inside there is 1 millimeter when it's so you're looking for 1 millimeter in the limb lanes and the anterior precordial leads is 2 millimeters in 2 consecutive leads. That is not actually what is the true definition. That is the working definition that everybody uses. The true definition was based on the studies of which they were done under when they were giving streptokinase to break clots up, and they wanted to put the bar high enough in diagnosing heart attacks. They wanted to put the bar high enough so that they weren't giving thrombolytics, these really dangerous drugs that can cause bleeding in the brain. They didn't want to give them to everybody, so they wanted to make a very high bar so we knew what we were doing. But that's actually not the most sensitive way. The more sensitive way would be 1 millimeter in the precordial leads. There's some studies that do 1 millimeter in 1 lead alone. But for increasing sensitivity, and your ability to find all these abnormalities, you decrease the specificity. You get a lot of them wrong. And so the definition can be a little bit better. There is a way to do proximal LAD occlusion just using AVR. If you have a 1 millimeter elevation with AVR and the appropriate circumstances, you could be having a heart attack. And I made a diagnosis with a man with that 6 years ago. Got in a screaming fight with another cardiologist. And luckily I won. And the guy was having an infarct. It was hereditary the widowmaker, which the guy probably would have died had we not, or had I not been able to bring him to life. So in the right circumstances, it can be, the definition is mutable. But for our purposes, it's 1 millimeter in the limb leads, 2 millimeters in the precordial leads, and 2 consecutive leads. You have to have 2 leads to do it. And let's go to number 9. We're talking about ST elevations here. Where are you seeing the ST elevations in this case? The shadow of the lead names. Remember, we read the ST elevations from the isoelectric line of the EKG. So where are you seeing that difference in the T wave in the little gesture? 2. Give me another one. 3. And AVF. 2, 3, and AVF. So remember when we talked about 2, 3, and AVF? Those are the inferior leads on the bottom. They're on the bottom of the EKG. So this patient is having an acute inferior lateral MI. And also there's ST segment depression just for fun. You can read in V2 and V3, you see that ST segments are depressed. That is probably because of either something called reciprocal changes, where you have a heart attack on the bottom of the heart, so on the front of the heart it looks like it's sagging. What we now know is that's not reciprocal changes as much as it probably represents multiple other blockages that are small, but not having a acute heart attack. So probably inferior wall MI with multivessel disease in this sense. Now, like I said, I'm telling you this not because I expect you to be able to read the EKG. I want you to see these EKGs. I want you to look at them. You can save these, put them downstairs, you look at them every now and then. So you can sort of get a pattern of, okay, yeah, this is narrow, this is wide, this is flutter, this is irregular, this is regular. And as we go through, and then we start doing more and more EKGs, we can start talking about more and more pattern recognition. Someone had a question over there.
Do I want to do a right-sided EKG on computer online?
So you can do what's called right-sided leads, or posterior. There's posterior leads, and there's right-sided leads. So right-sided leads. This is for those gunners out there that just want to know. You can move these leads anywhere you want. And if you want, you can move all of these leads over here to this side. And this is referred to as RB3, RB4, RB5, and RB6. And now, you're looking instead of at this side of the heart, you're looking at this side of the heart. It is not exactly right level. Because the heart doesn't look like that. What does the heart look like? In the chest cavity, it looks like that. And so the whole heart is sort of rotated, so the right side is actually the anterior and superior ventricle, and the left is the inferior and posterior ventricle. And it is more to the left side, the right side, somewhat more to the right side. It's all over here. So as you go out here, you're looking at it in this direction, but you're further away. And you're not looking at the whole thing, you're looking at portions of it. But yes, it can help you diagnose an RV infarct versus a non-RV infarct, as well as your AVR can help you, D1 and D2 can help you, and then if you have just isolated SC segment depressions in some of the D2 and SC segment depression, earlier always, if you flip it over, it's the opposite of an anterior wall line, and that's a posterior wall. That's the name of it. You can also do, if you want to, you can do, if this is V6 over here, you can do V7, V8, V9. You can move your limb from here and here, and here, it's called Lewis leads. So that you there's a whole bunch of things you can do with EKGs. Why? But you have to know the vector concept of what you're looking at and where the heart is sitting. And then once you do, you can make any diagnosis you want. There's a company that put out an EKG. It essentially looks like this. It's a big flat thing. Just press it down. Because now you're getting every single possible vector from the heart. You're getting a complete vector. There's another company that is I'm really interested in one now that does the whole thing by putting 3 leads on your chest, 2 on the shoulder and 1 here or something like that. And based on some electromagnetic, principle, it can create a complete 12-lead EKG out of it. I don't know how to do it. I'm intrigued by it because it can dramatically simplify the way we do EKGs if it's real. And one of the things we may be working on is doing a project where we occlude arteries during our cases. When I open up an angioplasty, I close the artery. Well, if we're doing that, I'm causing sort of a little brief heart attack, right? As I'm doing that, these SC segments will move around and we can make some diagnoses. It could be something we can use in the future. So there's a whole bunch of things that happen with EKGs that are not germane to us. Questions? More questions? Did I put everybody to sleep tonight? It's so much more exciting when I'm talking about cardiac arrest. Was another question? So we're going to talk about this more as we go forward. I'm really hoping that I can get you guys to start being able to do these in the ambulance. Like I said, the performance of the EKG is very simple. The interpretation of the EKG is very complex. We don't want you, at least initially, to worry about the interpretation. I want you to worry about the performance. And I think you can do it. I mean, people that don't have a high school education, that are med techs in our hospital that are able to do this. So I think you guys can do it. And so, wonderful. Oh yeah, I guess some of them don't have a
All right, everybody, final words. Come grab a sheet and I'll get the